Hopkins, Johns Hopkins Children's Center for Chronic Fatigue Clinic since 1996. He's a professor of pediatrics and the Sunshine Natural Wellbeing Foundation Chair in Chronic Fatigue and Related Disorders at Johns Hopkins University. He was the first researcher to describe the correlation between joint hypermobility, chronic fatigue, and orthostatic intolerance, sort of bringing together sort of all of our overlapping conditions that so many of us have. We're very happy to have him joining us today to discuss the complicated relationship between autonomic dysfunction and chronic fatigue syndrome. So with that, welcome, Dr. Rowe.
Thank you. Let me get the slides up. Okay, can you hear me?
Yep, we can hear you and we can see your slides.
Great. So as Lauren said, I've been working on this topic for about a quarter century, and I thought I'd take the opportunity to try to convey some lessons from the last 25 years. And the way I've set up the talk is to begin with a little bit of information to bring everyone up to speed on what we mean by ME/CFS, talk about the initial observations that we and others made about this overlap between orthostatic intolerance and the illness, look at evidence on orthostatic intolerance from the Institute of Medicine review that was done a few years ago. And then I want to share some new information that I think is really transformational on reductions in cerebral blood flow, brain blood flow, that have been developed by colleagues in the Netherlands, Dr. Linda van Kampen and Frans Visser, with whom I collaborate. And then I want to end with some very practical clinical lessons that will take us right up until the point of the COVID-19 pandemic, and why the information that we've learned in the last 25 years is going to be particularly relevant for people who develop symptoms after COVID-19 infection. So back in 2014, the Institute of Medicine convened a committee that I was part of, and many others in the ME/CFS world were part of, that looked at about 10,000 articles and tried to redefine this illness. And our concluding comment was that ME/CFS is a serious, chronic, complex, multi-system disease that often can profoundly limit the health and activity of affected patients. And we came up with a simpler case definition, and that required that you have these core symptoms that should occur at least half the time with at least moderate severity. The first was a substantial impairment in activities that were well tolerated before the illness, and that was usually accompanied by quite profound fatigue. The second was post-exertional malaise, a little bit of an unusual term, but it means that after exerting beyond the person's usual activities, they could provoke an increase in not just fatigue, but many other symptoms of the illness: lightheadedness, flu-like feelings, headaches, cognitive problems. And post-exertional malaise could be provoked by not only physical activity, but also cognitive activity. And we've subsequently learned that it can be provoked by orthostatic stress. Unrefreshing sleep was the third of the core symptoms, and the fourth could be either cognitive impairment, which looks just like you've acquired attention deficit disorder without the hyperactivity, or orthostatic intolerance. So taking a step back, let's think about ME/CFS itself. This is an illness that can often have a post-infectious onset. A number of studies in different countries have shown that after something like infectious mono, 10 to 13% of people will meet the ME/CFS criteria 6 months later. And in those studies, the main risk factor is not the person's prior psychological makeup, but it's the severity of the initial infection. We'll come back to that because I think COVID-19 is throwing a curve into this equation. We also know that some people don't have an obvious infectious onset. It can be a gradual, insidious onset in about 40%. One of the curious things is that it's uncommon, it's not unheard of, but it's uncommon before the age of 10. And there are two peaks in incidence that we've learned from some studies in Scandinavia. one between 10 and 19, and the other at 30 to 39. It's not, in other words, an illness that keeps getting more common the older you get. Our prevalence estimates, that is how many people have this, are not very good. We think it's somewhere around 0.5 per thousand teenagers and 4 per thousand adults. But that assumes that everybody is using the same definitions and naming the same symptoms in the same way. For example, some pediatricians might not like the term ME/CFS, so they'll term what the patient has POTS. Well, if POTS has a prevalence of 1 per 100 adolescents, then surely the ME/CFS prevalence is higher as well. A very consistent finding is that this is more commonly a disorder that affects females. Males are affected, but the ratio is 3 or 4 to 1, females to males. There's a genetic or familial factor in that monozygous or identical twins are more likely to both have the illness than fraternal twins. As Lauren mentioned, we saw this much more commonly in those with Ehlers-Danlos syndrome, and that work has been replicated by many other groups since the first publication. We also looked at our group with ME/CFS and found that they had a 3-fold higher risk of joint hypermobility than did people who didn't have ME/CFS. And how that relates to the onset of ME/CFS probably is due to the laxity of the connective tissues in the blood vessel wall. In terms of management, randomized controlled trial proven treatments for this illness are limited, but that doesn't mean there's nothing to be done. You don't have to be a therapeutic nihilist. We know that standard forms of symptomatic therapies can be effective for the orthostatic intolerance, for headaches, for chronic pain, for young women with menstrual dysfunction, for insomnia, and a variety of other comorbid conditions. So there's a lot one can do to try and help people manage. One of the things that was promoted a lot in the past was cognitive behavioral therapy, some people suggesting that it could be curative. But the enthusiasm for that position has waned. For one thing, none of the studies of CBT were properly blinded, and most did not have the kind of attention in the control group that the CBT participants had. The other thing was that the treatment effect sizes, that is how much CBT helped, were very modest. There were no studies in severely affected patients, and the largest of the CBT trials, the PACE trial, has become quite controversial because of emerging data on research misconduct, where the investigators changed the outcome measures that they had planned before the study was started in the middle of the trial. And when the data have been reanalyzed by independent investigators, they find that that CBT has virtually no benefit. The other thing is the rigid advancement of graded exercise that sometimes is incorporated by some CBT practitioners can cause harm and can provoke post-exertional malaise. So that is no longer used as a claim that it's a cure. When the Institute of Medicine made a summary statement about orthostatic intolerance, it said that sufficient evidence indicates a high prevalence of orthostatic intolerance in ME/CFS as measured by objective heart rate and blood pressure abnormalities during standing or head-up tilt testing, or by patient-reported exacerbation of orthostatic symptoms with standing in day-to-day life. These findings indicate that orthostatic intolerance is a common and clinically important finding in ME/CFS. Soon after the report came out, almost before the ink had dried, in fact, the proponents of cognitive behavioral therapy came out with the opposing view. Peter White wrote that orthostatic intolerance is questionable when good epidemiologic studies find that objective evidence of orthostatic intolerance occurs in a relatively small minority of patients. He said later in a different article, some would question whether orthostatic intolerance is a key feature. So you want to ask, why did he come to such a drastically different conclusion, and what difference would it make? Well, the implications of this kind of dissonance, this disagreement for the treatment, are that most of us who treat ME/CFS feel that treating the orthostatic intolerance is critical in managing the symptoms. And if you want to read more about that, you can look at the Frontiers in Pediatrics Open Access Pediatric ME/CFS Primer that we published in 2017. On the other hand, Peter White and others who are CBT proponents, their treatment guidelines that emphasize CBT make no mention of the utility of assessing for or treating comorbid orthostatic intolerance. I think because if they acknowledge that this problem exists, then their theory starts to crumble. So let's look at some of the initial observations about orthostatic intolerance and ME/CFS. One of the earliest papers was this one by McLean and Allen in 1940. And they said, we have given the name orthostatic tachycardia to a syndrome which is characterized by an excessive acceleration of the heart rate when patients change from the recumbent to the erect posture. Orthostatic exhaustion, blurring of vision, weakness on exercise, and syncopal episodes may occur. This is a syndrome which seems identical with effort syndrome, irritable heart, or neurocirculatory asthenia. Those were the names in that era for what we now call ME/CFS. And they actually made a number of really important physiologic observations. Here's one from 1944 where they showed that this was really due to a defect in a return of venous blood to the heart, so excessive pooling of blood. A concept that is still to this day recognized to be important in orthostatic intolerance. We got interested in the early 1990s when we had a number of patients that had chronic fatigue syndrome who also had the same features as patients with orthostatic intolerance. They got tired and lightheaded when they were standing still, shopping, or taking a hot shower. And we published the first paper in 1995. Two of my collaborators on this work were Issam Bohalega from Saudi Arabia and Hugh Calkins, who's the head of our electrophysiology lab at Hopkins. We went on to do a larger controlled study that was published in the Journal of the American Medical Association in 1995. And in that paper, I just want to emphasize a couple of things. We found that a history of lightheadedness was reported by 96% of those with ME/CFS. 83% had excessive sweating, 78% had blurred vision, and 43% had had syncopal episodes. Their fatigue was made worse by physical exertion, which you would expect by the definition of ME/CFS, but also by warm environments, hot showers, prolonged standing. And many of them would get more fatigued after a lightheaded episode, as is reported by people who have a vasovagal syncopal episode. When we looked at how they felt when we brought them upright on the tilt test to 70 degrees, they had an exacerbation of their typical symptoms. We had 23 people in this study. All of them reported worse fatigue. They had lightheadedness, warmth, nausea, and other symptoms, whereas the controls were simply bored. In stage 1 of the upright tilt test, which lasted 45 minutes at a 70-degree head-up angle, 16 of the 23 patients had a drop in blood pressure versus none of the healthy controls. So the odds ratio for an abnormal tilt in those with ME/CFS was a whopping 55, a huge number in terms of odds ratios in medicine. What got people's attention even more was that when we treated people openly with fludrocortisone, midodrine, and related medicines that were used for syncope, their overall wellness score, which is anchored at 0 for dying and 100 for as good as you could imagine feeling, their wellness score went from the mid-30s up to about 70 after 4 months of treatment. And this, in essence, is still the case when we treat orthostatic intolerance in ME/CFS patients today. So what did the Institute of Medicine review tell us? Well, in pediatric ME/CFS, all of the studies that have been done show that orthostatic intolerance is much more common in those with ME/CFS than in healthy people. Julian Stewart in New York showed about what we had seen, which was that 96% of his patients with ME/CFS also had orthostatic intolerance. And it was a mix of 18 with POTS, 22 with the neurally mediated hypotension, and a fair number of them also had acrocyanosis as a physical finding. Tanaka in Japan, with just 7 minutes of standing, showed that people had a delayed recovery of their cerebral oxygenation in most of the CFS patients and very few of the controls. One really interesting innovation was Vigard-Willer's design, where he had people only at a 20-degree head-up tilt angle, but that was enough to provoke heart rate and diastolic blood pressure changes and an increased sympathetic tone in the CFS patients. So it's a consistent finding in pediatrics. What about the adult data? This slide is meant to be somewhat unreadable. It lists the 14 studies that had healthy controls and had more than 10 minutes of prolonged testing. And the rates in the, of orthostatic intolerance in the first 45 minutes were close to 42% in the patients and 15% in the controls. So much lower initially than we were seeing in the pediatric patients. So let's move on to some newer data on cerebral blood flow, because I think this may explain why the initial observations might have been so low. If we look at the summary slide on the pathophysiology of orthostatic intolerance, in all cases, there seem to be a number of consistent physiologic changes. One is that patients have an increased amount of blood pooling in the lower half of their body, possibly due to a defect in their ability to constrict the blood vessels. In addition, there's a reduction in their overall vascular volume. And then when they stand, they have a reduction in brain blood flow. That provokes what David Goldstein calls a sympathoadrenal response, an increased sympathoadrenal response. And then the phenotype, the pattern that you can see with heart rate and blood pressure measurements, can include classical orthostatic hypotension, delayed orthostatic hypotension, neurally mediated or vasovagal hypotension, POTS, and then a proportion of patients have orthostatic symptoms but no heart rate and blood pressure changes. If we think that the key thing is the reduction in cerebral blood flow, then one of the problems that we saw was that we couldn't find it when we measured this by transcranial Doppler. So this was a study we published in 2003, and during tilt testing, healthy controls and ME/CFS patients didn't really differ significantly at different points. And you can see along the bottom that there was a supine measurement, 1 minute and 5 minutes into head-up tilt, and 5 minutes and 1 minute before the tilt terminated. So if the reduction in cerebral blood flow is key, why was this technique not identifying it? Well, one problem is that cerebral blood flow velocity by Doppler only identifies the not total flow, but how fast the flow is. And if the vessel narrows, then you're going to get an increase in cerebral blood flow velocity, but it doesn't tell you about true cerebral blood flow. Linda Van Kampen and Franz Visser came up with a new technique, which is in which they take a Doppler ultrasound and they put it for several seconds on each internal carotid and then each vertebral artery, and they can measure flow, total flow, add it up on all 4 vessels and give an estimate of total cerebral blood flow. And when you look at this slide from one of their talks, you can see on the left the tracing of the M mode of the Doppler that reflects the amount of blood flow going through with each heartbeat. And then that same person, when they're standing, you don't have to be a sonographer to see that the amount of flow is much lower. They applied this technique to a large study of adults with ME/CFS, and that was published earlier this year. And in this paper, they had 429 adults with ME/CFS, almost the entire, almost as many as the sum of the 14 studies that the Institute of Medicine reviewed. They looked at 44 controls, And this slide shows that 28% of their ME/CFS patients had POTS, 14 had delayed orthostatic hypotension. They weren't able to get their measures in people who had a precipitous drop in blood pressure because it took about a minute or two to get the readings. So those patients were not included. But 58% had what was a normal heart rate and blood pressure, and in some clinics might have been told, there's nothing wrong with you. Well, here was the money slide from that paper. They showed that between supine and 30 minutes of head-up tilt, the healthy people had a 7% reduction in their brain blood flow. The ME/CFS patients taken together had, on average, a 26% reduction. So almost 4 times the reduction in cerebral blood flow. And I think you could reasonably say, no wonder they can't think well, no wonder they're lightheaded, no wonder they're tired. What was really interesting is that in that large, almost 60% of patients who had a normal heart rate and blood pressure, if they had ME/CFS, they still had, on average, a 24% reduction in brain blood flow. It was a bit higher if you had POTS or delayed orthostatic hypotension, but I think this is the information that's really quite stunning. So it may be that we've been looking at the wrong targets for orthostatic intolerance in our ME/CFS patients, and maybe others who have orthostatic symptoms. And maybe as this technology and this form of testing becomes more widely accepted and available, we'll be better able to characterize our patients. So let me move on to some practical lessons. One is that patients with orthostatic intolerance have symptoms that overlap with ME/CFS, but the symptom severity is typically worse in those who have both conditions. So here, I think this was very nicely displayed by the group from Vanderbilt. In this paper from 2012, you can see that the patients who had POTS with CFS, meeting all the criteria from the older Fukuda definition, had a higher prevalence of these symptoms than the non-CFS POTS patients. But the non-CFS POTS still had a lot of fatigue, unrefreshing sleep, cognitive troubles, and even the post-exertional malaise, post-exertional fatigue. Second lesson is that orthostatic stress itself can provoke cognitive dysfunction in ME/CFS. And this was nicely illustrated in a study by Marvin Meadow and Julian Stewart, shown here, and their colleagues back in 2012, where as they increased the height of the tilt test and increased the complexity of a cognitive test called the NBAC test, patients had more symptoms or more problems. On the y-axis is their reaction time, how quickly they answered the cognitive test. And you can see that the patients and the controls were about equal at baseline, but after they were upright to 45 degrees or higher, there were more errors and more problems with reaction time. And the same thing happened in the bottom of this slide if you increased the complexity of the cognitive task. That work has been extended recently, again by Drs. Van Kampen and Visser. They showed that not only during the tilt, but also after the tilt, the cognitive problems persisted. So they were looking at pre-tilt and post-tilt with different complexity tests, a 2-back and a 3-back test, and you can see that post-tilt patients were doing worse. This applied to mild, moderate, and severe ME/CFS as well. They also looked at a rating scale of 0 to 10 in terms of the intensity of the concentration problems, and they compared healthy controls who really didn't have much trouble with concentration before the tilt and 7 days after the tilt. And you can see that in the ME/CFS patients, they had higher scores even a week later, whether they had fibromyalgia or not. This is a picture where we had introduced this couple to Baltimore crabs, Maryland crabs, and their hands are covered with the salt and spices, but you can see they were enjoying themselves. Third, inactivity is talked about a lot. We talk a lot about deconditioning, and I think the data on deconditioning are not as good as people would assume. Inactivity certainly can aggravate orthostatic intolerance in ME/CFS, but it's incorrect to view orthostatic intolerance as due exclusively to deconditioning. The Baltimore writer H.L. Mencken once wrote that for every complex problem, there's a solution that is simple, neat, and wrong. And that's the case for the concept of deconditioning as an adequate explanation for orthostatic intolerance in patients with ME/CFS. On the right, you see a picture of Michelle Akers, who in the late 80s and the early 90s was the top women's soccer player in the world. She was one of the leaders of the US women's national team, and she had ME/CFS, and here she is on our tilt table at Hopkins. I will point out that her symptoms got worse after the tilt, and she sent me this card thanking us, but said at the bottom, "No more tilt tables." Visser and Van Kampen also have published some data that look at this question about deconditioning, where they look at people's response on an exercise test. And if you've got a VO2 that goes above 85%, you're not really deconditioned. If it's below 85%, that counts as deconditioned. Notice, though, that their cerebral blood flow decline was basically the same. So the deconditioning had no influence on people's cerebral blood flow or orthostatic intolerance. So I think we need to really go back and look at that question. A related point is that while we want people to have better activity, it's unfair to ask them to do exercise work as the way to get there. It's a bit like asking somebody with asthma to take 4 laps around the football field, and then maybe I'll think of giving you a puffer, an inhaler to treat your asthma. We think that management of orthostatic intolerance usually enables people to tolerate graded increases in their activity. I'll give you an example. Here's a 22-year-old that we saw who had had the onset of fatigue and other symptoms in association with cytomegalovirus at 14. She managed to complete college in a full-time program, but it was mainly on grit and fumes. She got a little bit of benefit from an increase in salt and fluids and some compression garments, but I've shown on the bottom of this slide all of the orthostatic intolerance treatments that we tried on her that didn't make a difference. So she came in her early 20s, and by that point had developed an inappropriate resting tachycardia. Her heart rate as she came in seated in the clinic was between 104 and 140, very abnormal. And when she tried to exercise, which she tried fairly frequently, within 2 minutes, her heart rate would bump up to 180 beats per minute, and she'd get a 2-day exacerbation of her migraines. So it really made no sense to her to keep trying to exercise until we controlled this. Along came this drug Aberdeen, and with no Aberdeen on board, her resting heart rate was 115. She'd go up to 170 or 180 within 2 minutes, provoke a headache. As we got up to 5 milligrams twice a day of Aberdeen, the resting heart rate was down nicely to 90. Her heart rate reached 155 with exercise, and no longer was she getting a headache. And then on 10 milligrams twice a day, her resting heart rate was normal, and she would go up to about 130 beats with 30 to 40 minutes of exercise on the elliptical, again with no headache. So she had been trying to exercise but simply couldn't until we controlled her circulatory function. She is now working as an occupational therapist in Arizona, and I got this slide in an email from her. She made a weekend trip to Sedona and did 10 miles of hiking with the last hike up to Devil's Bridge. So the cognitive behavioral theologians would say that if you are active and physically able to exercise, you're set, you're all fixed. That's going to take care of your chronic fatigue syndrome. The problem is that it doesn't work that way. And so here's what happens to this young woman. Every year, the insurance companies ask us to provide a new prior authorization for her Aberdeen. So here she is, fit, able to do 10 miles of hiking in a day. But she goes off the Aberdeen and gets an immediate return of her fatigue, lightheadedness, and some cognitive fogginess. Again, that shouldn't happen if the CBT people are correct. So again, I think they have missed the boat on the importance of orthostatic intolerance and its treatment in this illness. Other factors can influence orthostatic symptoms in this illness, including a lot of neural tension dysfunction and tightness, even among those with hypermobility. So this is a slide that we use in our clinic to talk about all of the different factors that can have an influence on orthostatic intolerance and fatigue. And you've heard about some of them during the conference, I'm sure. Mast cell activation syndrome, milk protein hypersensitivity, which we see in 30% of our patients. And that's recognized by epigastric pain, reflux, and early satiety. The movement restrictions can include limited straight leg raise, thoracic outlet syndrome, and other areas of tightness that are often better identified by good physical therapists. And one thing that is getting more and more attention is the fact that neuroanatomic problems can contribute, whether it's a Chiari malformation, cervical spinal stenosis, or craniocervical instability. We're not sure of the prevalence of each of these, but these may be worth looking for in your most refractory patients. It's a heterogeneous condition, and we have to ask ME/CFS due to what? This slide shows a paper we published 2 years ago on 3 young women who had absolutely refractory POTS and NMH and chronic fatigue syndrome symptoms. All of them were basically housebound, unable to work. One of them, who I had examined for 7 years, finally had an abnormal Hoffman sign, a test that gives you an involuntary flexion of the fingers after flicking the end of the third finger. That indicated that she might have a problem in the cervical spine. We got an MRI, and you don't have to be a radiologist to see that there's very little spinal fluid on either side of her cervical cord. She had an 8mm diameter. Normal is 13 millimeters of space between the front and back of the spinal cord. And in addition to her congenital cervical stenosis, she had a disc bulge here that was further compressing the spinal cord. Her orthopedic surgeon said, I don't know much about the fatigue and lightheadedness and tachycardia you've got, but I know that if we don't fix this, you're going to have trouble if you get into a car accident. So he did a disc replacement. Within 2 months, this girl who hadn't been in school in 4 years was able to take a job as a dog walker. 6 months later, she was saddling horses and taking people out on rides in the Colorado Rocky Mountains. 9 months later, when September came around, she started as a full-time university student, flew through it with no limitations or accommodations, and currently she works as an international aid worker who does rock climbing as her main hobby, I think primarily to trigger a heart attack in her doctor. Anyway, this was the case for the other 2 people as well, so we always have to do a careful neurologic exam and look for other things that can be contributing to symptoms. I want to end with just a story about ME/CFS and orthostatic intolerance appearing following COVID-19. Here's a 30-year-old woman who was asked to start working from home when the coronavirus pandemic began in Maryland. 2 days later, her employer called and said there was a positive COVID-19 case in a coworker 2 offices away from hers. She was also starting to develop fatigue, and she had a low-grade fever at the time. She was somebody who had been meticulously measuring her basal body temperature daily. So she had a beautiful chart showing her temperature was usually 36.2 to 36.8. No deviations outside of that range. Now she was 37.7 and she had a mild cough. But from the very beginning, even with mild respiratory symptoms, she had lightheadedness. She couldn't stay upright for more than a few minutes, and she would slide off to the side when she was seated. By the 5th day of illness, she had a loss of taste and smell. That lasted 6 weeks and remained primarily in bed for the first month of the illness due to her inability to be upright for more than 2 minutes. And she had tremendous fatigue in the beginning. people used to say on occasion that the orthostatic intolerance was a late phenomenon with ME/CFS, that it was just because people were lying around too much in the beginning. Not the case here. She had it from the very beginning. By 10 days in, she was having so much trouble with cognitive function that despite being a high-level scientist, she couldn't make sense of the numbers on her bank statement, and she couldn't follow the plot of a TV program. And she remains ill to this day. Here's her standing test that we got about 5 months into the illness. Her heart rate at rest was relatively elevated, near 100, and it went up a whopping 77 beats per minute, and her peak heart rate standing, doing nothing other than leaning against the wall, was 166. This provoked her typical symptoms. And what I hope this kind of case helps to do is to remind people who are not familiar with autonomic dysfunction and orthostatic intolerance that anybody with severe fatigue post-COVID needs to be looked at for this kind of orthostatic intolerance, because it provides a completely different way of treating them that might be more effective. We obviously have many more patients to study, but we've seen 3 with this kind of pattern with severe POTS and severe fatigue. One of those patients being a young man who was capable of running on his cross-country team 60 to 70 miles a week before he was hit with COVID. And now he can't play a game of cornhole in the backyard, which for people in other countries is a sort of game like horseshoes, without getting 4 or 5 days of post-exertional worsening. One of the resources that is published in an open access journal and is available to everyone free of charge is this primer that Julian and Marvin Meadow and a number of others of us wrote and published. This has a lot of information on managing orthostatic intolerance as well as the other symptoms of ME/CFS. So please take a look at that. And I'll end just by thanking the people that have made it possible for me to do my work at Johns Hopkins. We had some grants in the 1990s. The Sunshine Natural Wellbeing Foundation has endowed the professorship that helps make my time totally devoted to these conditions. We've had a wonderful research coordinator, Colleen Marden, over the years. We've had some fantastic summer students, many of whom have gone on to work in the health professions. And we've had a lot of generosity from families and patients who have helped provide salary support for me. We've just hired a nurse for the first time in 25 years, and we're hoping to expand the clinic with another faculty member. So I'm going to stop there and see if we've got questions. And Lauren, do you need me to?
Sure, you can just stay on camera and I'll stay on camera. Thank you so much. That was a great talk. This is such an important issue. There's a huge overlap between dysautonomia and ME/CFS, and we have so many questions. So if anyone wants, you can type in questions. If you hover over your Zoom screen, at the bottom there's Q&A, and you can type in questions. I'll try to get to as many as possible, but from the prior few days of sessions, we usually have hundreds of questions and can only get to a few. So please keep your questions to sort of generally relevant topics rather than asking for personal medical advice. So some of the questions I had already pulled from the list. Are there any long-term effects of ivabradine that you are aware of?
We haven't seen any, and I don't know the literature well. I haven't looked at that literature well enough to be entirely sure, but we feel like it's a pretty safe drug long-term. Some people will get a bit of light sensitivity in the beginning when they use it, but that and sometimes some swelling, but those things can disappear.
So we know from POTS and orthostatic intolerance that those conditions can be triggered by post-infectious onset, post-concussive onset, surgeries, pregnancies. Does ME/CFS have that same kind of profile, or is it mostly post-infectious?
It's very similar, very similar. I don't think you can find a line that discriminates between them. You can get it after trauma, infection, a variety of different stressors to the system. One of the theories is that when whatever is the trigger initiates a systemic stress response that never turns off. But what that might be is unclear.
Yeah. So a big question we hear a lot on our support groups and we see discussed on the MECFS support groups is the topic of exercise. So POTS doctors generally heavily push the exercise on POTS patients to varying degrees. Some people are sort of fanatical about exercise as the cure, and then other doctors will probably take a more practical approach where it's good to exercise, but don't super overdo it and make yourself feel worse. And then in the chronic fatigue world, we have a lot of people who are really worried that exercise causes progression and worsening that is permanent. If a patient is diagnosed with both MECFS and POTS or MECFS and orthostatic intolerance, what do you advise in terms of, where to strike that balance on the exercise spectrum?
Yeah, and I think if I can say this, I think in the MECFS field, there's been such a reaction to the older incorrect notions from the CBT enthusiasts that all you needed to do was gradually increase your exercise and they would force you to do it regardless of how you were feeling. Yeah. And people in the MECFS world said, look, this is harmful. And so some of them have gone as far as to say that exercise of any sort is bad for you. Well, that becomes a bit counterproductive because we want to get people from the point they are to much closer to normal activity. And we have to be very sensitive to how they're managing. We need to support their circulation in order to allow them to be more active. And we have to begin with a mild amount of exercise and increase gradually. We had one girl, for example, early in our experience, who I use as an example all the time. She was feeling better on her fludrocortisone and atenolol and realized that she was able to do a bit more, and she wanted to know how she could regain her fitness. And I said, start with something that doesn't make you lightheaded. So she tried a treadmill if she was too lightheaded. Then she found a reclining exercise bike. That was better for her. And I said, start with an amount that doesn't flare you up and increase gradually. So she started with 3 minutes on the bike, which is a nothing amount for most people, but she was very disciplined, and every 3 days that did not flare up post-exertional malaise, she increased by a small amount, 30 seconds. Maybe that was too cautious, but in any event, it worked for her. Within 2 months, she was up to a half an hour a day, which any of us would be quite pleased that we were doing. So I think that's an example of what we mean by activity. You've got to have a balance. And like I showed with the girl who went on the Aberdeen, she simply couldn't exercise her way out of that. I think that's the key lesson, is that you've got to have the medical problems addressed in order to then take advantage of whatever it is that exercise provides for us in helping with functioning normally.
Yeah. I'm going to share my own little anecdote. Earlier, I've had this kind of milieu of diagnoses for 10 years now. But in the beginning, I was told I had MECFS and POTS and fibro, like all the syndromes. And I tried the Levine exercise protocol, which a lot of the POTS doctors promote, especially back then when it first came out. And it was pretty intense. It was like starting with like 45 minutes a day. It was reclined exercises, which is very important, I think, to emphasize for patients with any kind of orthostatic or dysautonomia type problem. You have to start your exercises laying down, reclined, seated. A lot of our patients are people who were super athletic before they got sick. So a lot of them have that mindset of, oh, well, I'm feeling awful, maybe I just can work out. And they try to jump into the treadmill or the 5K jog or something like that. And, it's even if you feel like you can do more, maybe just starting super slow is important. So for me, I had been a big, very athletic person before this. And I just kicked my own butt, like unintentionally, by trying to do too much. And then when I learned that I had to kind of really take baby steps and start slow, that's when I was able to make some very slow progress. I actually did my best rehab playing Beatles Rock Band on my Wii. Drumming like Ringo is actually a really good workout.
Well, and if you can make it fun as well. The other thing that we've found that's incredibly helpful for improving tolerance of activity is get seen by somebody who's a really good physical therapist, but who practices manually based therapy rather than exercise based therapy, where they address restrictions in movement inefficient use of muscles, muscle tightness and spasm, myofascial tightness. Get them to help you tolerate the exercise and begin slowly. But I think manual physical therapy in our practice has been a really good bridge to tolerating more normal activity.
Mm-hmm. You had mentioned cerebral blood flow test results, research papers, and this comes up in the POTS world too. Are there recommendations for patients to seek out that testing, or is that more of a research-based approach right now?
Right now, it's research-based. The group in Amsterdam has a tremendous facility with it. They feel that it's got very good reliability and validity, but we don't even offer it at Johns Hopkins at this point. We're trying to get our ultrasonographers interested because I think it gives us way more information. And instead of falsely telling people who have a normal heart rate and blood pressure with their orthostatic symptoms that they're fine, this is a way of actually determining what's going wrong. As an example, in Amsterdam, they've had a couple of patients who were diagnosed with psychogenic pseudo syncope, meaning these people had to be faking their falls and collapses. A couple of those patients had a 40% reduction in cerebral blood flow. I want to see the critics stand up when they've got a 40% reduction in blood flow and tell me that's psychogenic.
Right. You tell them, doctor. So anyways, I have another question actually related to that. So are there any medications or lifestyle treatments that are known to increase I mean, I think all of the lifestyle treatments meant for orthostatic intolerance are to increase cerebral blood flow, but can you talk to specifics on medications that might help?
Yeah, I don't think we have any except the ones that you mentioned that address overall venous pooling and orthostatic intolerance. It might be the case that because hyperventilation and hypocapnia can cause a reduction in cerebral blood flow, that things that address hypocapnia might be beneficial, but I'm not aware of a lot of work that's been done on that. I might need others to chip in on that comment.
I know that some of the doctors on our board use like ADHD type drugs to help with the brain fog, which in theory might be doing something to cerebral blood flow, but I don't know the data off the top of my head.
I would argue that the stimulants are very potent vasoconstrictors. So they are probably helping with cerebral blood flow by the same mechanism that something like midodrine is having. So they are very good vasoconstrictors. We use them more than we use midodrine in the adolescent and young adult population because you can get a sustained release form of a stimulant that lasts 8 to 12 hours. And so you get whatever extra benefit the central effect of the stimulants can have on cognitive function. But I think the primary effect is on reducing their lightheadedness and improving the orthostatic intolerance.
So this question is sort of a can of worms, but it's a good question. Is there data showing what percentage of adult and pediatric, kind of considered differently, what percentage of ME/CFS patients improve over time and what percentage might actually recover fully over time? Do you have that kind of data?
I don't think anyone has great data. Kathy Rowe, who's no relation to me, but a very experienced and excellent pediatric ME/CFS clinician, has published a paper in Frontiers in Pediatrics on the experience with 800 Australian adolescents with ME/CFS. Some people improve, some people get a lot of, they learn to live with their illness better, they have partial improvements, and they put up with a certain number of symptoms. And others, even when they say they're fully improved, that the illness has resolved, really still have, they report some of the same symptoms. But we don't have great outcome data, and we don't have good natural history data because I wouldn't do a natural history study. I want to treat people from the beginning, and each of us has a somewhat different method of treating patients.
Right. We know that POTS and EDS tend to run in families, although we don't, for either of those, at least for hypermobile EDS, we don't have specific genes yet. or POTS. Are there papers showing that ME/CFS, like risk for developing this, runs in families?
There are a number of papers showing that there's more ME/CFS in first-degree relatives. There's a big study using the Utah genetics databases, and I think that's been everybody's clinical experience as well.
Yeah, and then so there's a whole bunch of questions about sort of touching on this topic that is something that's actually probably every expert in these fields has a different opinion on. What is the real difference if you know, if a patient has POTS and ME/CFS? What is the real substantive difference between those two diagnoses? How, in your perspective, like how do you classify those as two different things, or maybe you don't?
I tend to look at things along the spectrum. I think almost everybody has orthostatic intolerance when they have ME/CFS. It may be the most important driver of symptoms. A subset of them will have POTS as their form of orthostatic intolerance, but a lot of others, as you saw from the data from the Netherlands, have either no heart rate and blood pressure changes over 30 minutes, but they're really symptomatic, or they have some form of hypotension. The good news is that it doesn't really matter. The drugs that we use for POTS or hypotension or syncope are all pretty much the same.
Mm-hmm, mm-hmm. I think that the question as to, you know, the overlap between POTS and ME/CFS and NOI, whether they're the same thing or they're different, I think that we need research to answer that. There's this concept in medicine that I know you know, but for our audience, some doctors are lumpers and some doctors are splitters, right? And right now we have these diagnoses that are kind of big, broad lumps. They have a lot of different types of people getting the same broad diagnoses. And then over time with research, we're going to be able to pinpoint subsets of these populations that have more specific, hopefully understanding the pathology. You know, 30% of patients have this and 60% have this. So if for patients out there, you know, I think right now we're all lumped, and someday with more research, we're going to be more precisely diagnosed with more precise treatment options. I think a lot of the you know, you hear about all the drugs that are used in these conditions, and you'll hear a lot of people saying, well, that didn't work for me. And it might be because we've all lumped everything together, and someday, you know, we will have a little bit more ability to target our treatments based on their underlying pathologies.
I'll comment on that, Lauren, that, you know, for our patients who have a history of milk protein intolerance, again, we see it in about 30% of our patients. We can often get a history that when they were babies, they had a lot of colic and regurgitation that was excessive, and they needed to be switched from a milk-based formula to something like a soy-based or amino acid formula. Then they start to tolerate milk, then something happens, maybe mono, to trigger their ME/CFS, and at the same time, it seems to revert the immune system back to the way it was in infancy, where it was intolerant of milk protein. And if we've got a patient that has those cardinal features of epigastric pain, reflux, and early satiety, getting full easily, if we don't get milk out of the picture at the beginning, none of the other medicines seem to work. It's like you're trying to put out a fire, but you're throwing gasoline on it at the same time.
Here's a great question that could be a whole lecture in itself, but you've got 2 minutes to answer it.
I'll let Mitch can answer that one.
Oh, Mitch is going to tell us about COVID, but the next, that's the next session. But what do you do when you have an ME/CFS patient walk in your clinic for the first time? What is your workup that you do to rule out other things and try to identify what's going on with them individually?
So the vast majority of what we do is a detailed history to really get the story straight. And then we do a careful neurologic and general examination. We're looking for all of those comorbid things that I showed on the one slide, the mast cell features. Do they have flushing? Do they have rashes? We look for evidence of tightness on a variety of things that are usually examined by physical therapists, but which I've incorporated after some teaching by my colleague Rick Violand into my exam. And then we do a standing test in everybody. We do a number of sort of baseline blood tests looking for other organ system dysfunction as a cause of the fatigue, but we don't do even a tilt test in everybody because I can get most of the information I want from a standing test in an adolescent or young adult. We don't typically do some of the things that some of the other autonomic experts get in adults because we just don't see the problems often enough in the kids to warrant it. So things like, we don't do the Valsalva ratios. They're usually normal in ME/CFS anyway. We don't do other things like the QSART, and we don't typically get a skin biopsy for small fiber neuropathy unless the person is reporting other more characteristic symptoms. We just don't see it that much in the kids as far as we know.